Welcome everybody to this afternoon's Center for Evolution and Medicine speaker series talk. It is my great pleasure and honor to introduce Dr. Ines Varela-Silva. She is a senior lecturer in human biology at Loughborough University. She earned her Master's of Science in Health and Sports at the University of Lisbon before going on to earn a Master's of Science in Management of Educational Resources and a PhD in Human Growth and Development by studying growth and development among Cape Verdean immigrant population community in Lisbon, Portugal. She pursued postdoctoral training in biological anthropology at the University of Michigan and has published dozens of scholarly articles on her work at the intersections of human development and physical activity. She is the director of the Maya Project, an initiative that blends art and research outputs to depict the biosocial realities of the Maya in Mesoamerica. And this is done through art exhibitions and public talks. So she's deeply invested in knowledge translation to multiple audiences. Among her numerous professional accomplishments, Dr. Varela-Silva is a fellow of the Royal Anthropological Institute. She's a fellow of the Royal Society of the Arts, and she has been awarded for her efforts in Equality and Diversity Action Group Award. Just a really impressive portfolio that demonstrates the 4 pillars of scholarship in the 21st century: research, education, service, and outreach, and is just an incredibly important and special scholar in our community. I would welcome you to join me in thanking her for giving her presentation on the multiple burdens of malnutrition among Maya families in Yucatan, Mexico, a bottom-up approach. Welcome, Dr. Ines Varela-Silva.
Thank you very much. Thank you so much, Katie, Noah, Suhail, Jennifer, and everybody who is taking your time and your effort to just attend another Zoom meeting to listen to my talk. I'm really, really happy and very honored to be giving this talk to you, and I hope you find it useful. I certainly found it, really, really great to be putting this together and to be able to share my research, the old and the new research that is now coming to, I guess, a new way of my being in academia. I hope so. So thank you very much, and welcome. It's evening here, so welcome to England in the evening, and wherever you are in the world, I hope all is going well and everybody is safe. So as Katie, Dr. Hin said, my talk is about multiple burdens of malnutrition among the Maya families in Mexico. I've been working with the Maya since 2005, and I use a bottom-up approach, which I will explain that in the next slides. So I don't think I can do much more after the amazing introduction that Katie did to me, but if I had to give you a research statement, these would be my research statements. So I'm a human biologist, and I am at Loughborough University. Yes, that big word is Loughborough, and it's in the UK, and I have a map to show where it is. And if I have to summarize what I do, I would say that I use a biocultural approach to study health and nutritional outcomes among families in low and middle income countries. Most of my work is in Latin America, but I have some PhD students doing similar work in Ghana and in Nigeria, and I still have some connections in Portugal and with the migrant communities from Cabo Verde. So the main purpose of my research is to understand how intergenerational and early life conditions associated with poverty and discrimination lead to child malnutrition in all its forms, and how they potentiate health and disease outcomes throughout the life course. So that would be my research statement. If you want to know more about Loughborough, this is our oldest and most iconic building, and this is the website, the link for the website of the university. We have 10 schools. I am in the School of Sport, Exercise and Health Sciences, which has programs in psychology, sports of all sorts, and the human biology program. And our school is, by some metrics that I can't tell you right now exactly what they are, but we've been rated the #1 in the world for 4 years in a row for all sport-related matters. And Loughborough is exactly here in the middle of England, about 2 hours northwest of London, and really as further as possible from the ocean, considering that we are in an island. So here we are in the heart of rural England, and it's actually a lovely place to be. And I hope that once this pandemic is over, I can have the honor to have some of, any of you come and visit, because it's a really, really nice place to be, and it's a really good place to work. So that's where I am. And for the summary of my talk today, so I'll be giving a little bit of an overview about the multiple burdens of malnutrition in general. And then I will narrow it down to the work that not just me, but all the great people that I have in my team that we've been doing since I started there in 2005. So a little bit of the way the Maya families and the research we do in Yucatan. And then a little overview of the projects in terms of past, present, and future, because I'm on a big change in terms of ideas. And then I'm going to talk about the ways we do bottom-up approach and the way we spread out what we find out in terms of the research results. So I hope you find it interesting, and I will start by defining malnutrition according to the WHO. So when we talk about malnutrition, we talk about all its forms, not just undernutrition, and sometimes these two words are used indistinguishable at this point for the purpose of this talk. Malnutrition includes all the conditions associated with undernutrition, so wasting, stunting, underweight. Includes also the other part of the spectrum on overweight and obesity. Includes inadequate vitamins and minerals, and then all the resulting diet-related non-communicable diseases. For people who are not very much into this terminology, so wasting is an indicator of acute malnutrition. Stunting is an indicator of chronic malnutrition, and underweight is an indication that the overall status of the child, because these conditions are focused, we study them in children. It's where the whole undernutrition characteristics are not that well. And then, of course, on the other end, we have overweight and obesity and all the related non-communicable diseases. And to give you an idea about the scope of the problem, we see here that globally, and this is data that just came out a couple of months ago from the Global Nutrition Report, we see that among children between 0 and 59 months, there's about 22.2% of children globally who are stunted children, so very short for their height, with outcomes of health and disease that will linger for life. And that is unacceptably high. We have less in terms of wasted children, because wasting is seen when we put in perspective the weight of the child in relation to their age. So it's less of a problem, but still 7.5%. It's still 50 million children who are wasted. And we are starting to have a very big concern of overweight children. At this point, globally 5.6%. And even if this was not bad enough, we start seeing here on this chart below that every country in the world is affected by malnutrition. And in some cases, we are starting to have these conditions piling up together and becoming multiple burdens of malnutrition. So for example, in this chart down here, the darker the orange is, the more burdens are seen together. So the yellowish kind of color is a country that is dealing at least or struggling with at least one single burden. When we have the intermediate color in some little bit more darker orange, there's at least a double burden, which means that, for example, there is coexistence of stunting and, for example, overweight, or stunting and anemia, or overweight and anemia. And when we have the darkest orange, we see that the countries are facing triple burdens of malnutrition. And obviously we see that the most affected countries are the ones who are also the poorest. And in this case, it's Africa, South America with lots of double burden, and all part of India, Bangladesh, and all the Asia with at least a double burden. So it is unacceptably high, and the conditions are piling up together with exponentially bad results. Okay. So when we divide this a little bit more into, for example, the fragility of the countries, and there's the fragile index of that, it's a composite measurement that associates several indicators, demographic and political and economic and social. And what we see is that the more fragile the countries, the bigger the burdens at higher percentages. So among the 15 extremely fragile countries in the world, we have 46.7% of those countries struggling with overweight, anemia, and stunting. So a triple burden here. And then half of the other of this percentage with a double burden of anemia and stunting. On the fragile countries, which are 43 countries, we also have a great deal of a triple burden and the same anemia and stunting. So we see that these conditions will become more and more problematic as the fragility index goes higher, which of course potentiates a lot of many other negative outcomes. And the world is not doing great, because if we consider the global nutrition targets for 2025, so in just 5 years from now, there are these targets, so reduction of stunting by 40%, reduction of anemia in women of reproductive age about 50%, decrease in birth weight, they aim at 30%, childhood overweight, the only aim is let's not, no increase, increase the rate of exclusive breastfeeding up to 50%, and try to maintain and reduce and at least maintain childhood wasting. So these are the targets, and the picture that shows in terms of the way we are is not really great. So, sorry, let me just, pardon me. So what we have here is, in blue, the countries that are on course to reach the global nutrition targets. And we have progress in 41 countries in terms of childhood overweight, progress in 40 countries in wasting, and so on and so forth. But the problematic thing here in this chart is that this orange bar shows that, for example, in terms of reaching the target for anemia, 138 countries in the world have no progress, or actually the situation is getting worse. Low birth weight, we have 85 countries that are doing worse, and they will not definitely reach the targets. And it goes down for the other conditions. And these are in children, and these are in adults. And what we see is that nothing, or most of the countries, are off course in terms of obesity for men and women, in terms of diabetes for men, and in diabetes for women. So all these global nutrition targets for 2025, most of them will not be achieved. And actually the situation is getting worse. So it is problematic, and we need to try at least to understand why after so many money put in this kind of research, so tremendous amount of money that all around the world is spent in interventions, why do we still have, after all this time, such a grim picture in terms of not meeting these targets? I would like to just make a pause here and share with you this quote from Maya Angelou that I'm sure that you all know. You may shoot me with your words, you may cut me with your eyes, you may kill me with your hatefulness, but still like air, I'll rise. And yes, countries are doing the best they can, and there's lots of people really trying to overcome all of these terrible situations that people are living on, and it's very aspirational, it's very inspirational. But when we are talking about malnutrition, we know, and this is another quote from Maya Angelou, that we are the sum total of everything we've ever seen, heard, eaten, smelled, been told, forgot, it's all there. Everything influences each of us. And this bit of poetry, just to say that in terms of malnutrition, people will rise, people will overcome, but there will be scars that will stay forever, because we do not adapt to malnutrition, and children suffering and the family suffering will have a trade-off that sooner or later it will be felt, and it will be somehow paid with interest later in life. And that is very problematic, because these conditions will linger for life and will affect not just the generation that is experienced them, but the generations that haven't been born yet. And this is particularly true with stunting. Okay, so making now the transition to the research that I do in Mexico with the Maya people. The Maya people are one of the major ethnic groups, and they are mostly distributed between Guatemala, Mexico, and Belize. Back in 2012, when the Mayan calendar predicted very wrongly, obviously, that the end of the world was about to come, people start talking about the Maya, and then I realized that most people thought that the Maya were extinct. And they didn't actually realize that there are about 8 million Maya in Latin America and in communities of migrants around the world. So they are the cultural and biological descendants of the pre-conquest Maya. So these Maya people that we see when, this is in Cancun, which is where most people probably are more connected. This is Chichen Itza. So the current Maya, the living Maya, are cultural and biological descendants of the pre-conquest Maya. They speak Spanish because they were colonized, but there are about, I think, if I'm not mistaken, 34 Mayan languages. And in the communities that I work, the Mayan is Yucatan Mayan, which is very different from the Mayan languages that are spoken all across Guatemala. And where do they live? So the Maya live here. So this is United States, Florida, Mexico is a big country. And then we have the Yucatan Peninsula, Cancun is here. And the research that I work is in Merida, mostly that's where I usually stay, but around this area here of the Yucatan Peninsula. And then of course there are Maya in Guatemala, in Belize, in El Salvador, and a little bit of Honduras. So this is the Maya area. And how are the Maya doing? So as I said, the Maya are the largest indigenous group in Yucatan. And data that we got from 2017 show that the Maya in Yucatan lag behind in all social, demographic, and health related indicators. And they have pretty good data from the state health department. So we can say with a great degree of certainty that they are not doing well. They have life trajectories that are very different from non-indigenous groups in the same area, because the Maya suffer systemic trauma, poverty, they have unequal access to healthcare and education, and they are still suffering lots of systemic racism that reflects on every part of their lives. From the statistics that we have at the state level, 20% of Yucatec children are stunted or short height for age, 20% have iron deficiency anemia, and 50% are overweight or obese. And then, of course, we have the combinations that make many of these children becoming a dual burden child at very early age. And over 40% of the adults are overweight and obesity. So we have all these multiple burdens of malnutrition, disproportionately impacting a group of people in the Yucatan because of several socio-demographic and political economic conditions that have been hitting them for generations without any kind of relief. Okay. So how are they doing? Yucatan overall ranks 7th. There are 31 states in Mexico and the Mexico City Federal District. So out of 32 federal entities, Yucatan is in the 7th in terms of social inequality, marginalization rates, and the Maya are at the bottom of those statistics. So the state as a whole is not in great shape. The Maya are at the bottom of that state. And then this is something that I'm now starting to do, is to figure out the impact of language on health outcomes. So we start doing some research about how much is still spoken in Yucatec Mayan and how much self-identification as indigenous groups are still around. And the results have shown that 30% of the population speaks Yucatec Mayan and 62% self-identify as indigenous. So we can say that language in the Maya case is both a synonym of ethnic identity and it's also a reliable proxy of negative health outcomes. So language definitely is something that as biological anthropologists and human biologists working in these sorts of environments, we need to start paying more attention to. Otherwise, we are missing a very big component of information that can be then put into the context of any health or educational outcome. And it can make a difference because language is a predictor and is determinant of some health and some well-being indicators. Okay, so basically what I've been doing since 2005, the first time I set foot in Yucatan, in terms of the research with the Maya, is basically the traditional nutritional status studies. We go to the schools, we measure the children, measure the mothers, we convert it into Z scores, and then we give percentage of how many stunted children, how many overweight, and then we try and figure out, you know, if there's influences of education or if there's a bathroom in the house. So the basic biocultural approach that I think most of you are well aware of. And you could have been doing these for the rest of our lives because there's lots of data and lots of stuff to do. So in terms of the research, yes, the Maya are very stunted, they are very overweight and obese, and these outcomes in terms of phenotype are associated with poor education of the mothers, really low-grade jobs with big job insecurity, very poor living conditions, and a situation that there's segregation in access to healthcare, in access to medication, and actually just in terms of the way they can live within the state of Yucatan, it's also very segregated. And of course, it impacts on the health. We have some results on birth outcomes, and there is data that shows that birth weight has an impact on health outcomes by the time that the children are in school. There is not a great deal of low birth weight, so it is not something in the womb that will potentiate then the great amount of stunting, because low birth weight is overall okay. But by the time the children are 2 years of age, we start seeing the level of stunting starting to creep up. So what's happening is something that, something happens very negatively, probably around the weaning time, around 4 to 6 months of age, when complementary foods are starting to be given to the children. They start being weaned from their mother's milk, breastfeeding, and that's when we see everything falling off the charts. We have a little bit of data on maturation studies that basically show that age of menarche is delayed and age of adrenarche is also delayed. So they are maturationally, in terms of maturation indicators, they are delayed. We have some intergenerational studies that show that the living conditions and the growing environment of the mothers and grandmothers still have an impact on the generation that we measured. So we have 2 PhD students of 2 of my students, one that shows that, both of them show that an association between bad living conditions of the mothers when they're growing up and most of the linear anthropometric measures, so in terms of height, body proportions, leg lengths. And the PhD student of Hugo Ascorra, who went back and he was able to measure 230 triads, so children, mothers, and maternal grandmothers. And he found some associations between the living conditions of the grandmothers when they were growing up and fat patterns, so subcutaneous accumulation of subcutaneous fat, mostly around the waist. So the grandmothers who had the worst indicators of bad living conditions when they were growing up, the kids of those grandmothers were the ones who had highest levels, higher percentage of centralized accumulation of fat. And then we have some lifestyle studies that show, for example, that yes, they are totally on the, they've done nutritional transition completely. So they are very much running away from traditional foods, eating a great deal of junk food, high caloric food, with not so many nutrients. They are in a double burden in terms of epidemiological transition. So they're still dealing with lots of infections, mostly gastrointestinal infections and mostly respiratory infections. There's still lots of parasites. There's still lots of diarrhea, but also now we start seeing the overweight and obesity and all the outcomes of that in terms of non-communicable diseases. And what we also saw in a very small sample was that, however, we have these all stunted children, which we know that stunting then associates with less muscle mass. But what we see is that even the most stunted kids do not have a problem of being sedentary. So we put some actigraphs on the children, and even the stunted ones are above the regular daily level of activity that WHO recommends. So we have a great deal of overweight and obesity, but that is not because these children are sedentary, because they are actually active. The problem is what they eat and all the non-genomic intergenerational effects that will potentiate further accumulation of subcutaneous fat at much higher rates than you see in children that didn't go through this level of suffering. And as I said, this is basically what most people do in biological anthropology, and we can keep doing this forever. But we are missing stuff. And for that, we have to go out of our comfort zone, which I've done, and start moving to other topics and involving other people. And actually, the first thing we have to do is to involve the Maya themselves. Okay, because this idea of us going, asking permission, and they of course they give you permission. And then you go to schools and we measure all the kids and then we try and but we really don't listen to what the families say. I mean, we listen what we ask them to tell us in the questionnaires, on the interviews, but we really don't ask them, what do you want to know, or what do you want us to do with this research that we can do here? So the first step is asking people not what it's on the questionnaires, but in which way do you want to be involved in this research, and really bringing the communities and bringing the community leaders and the mothers in the way that then we can shape the design questions with the input of the community. So with the research involving the families, we give the families a voice before we decide on the design of the research. And this is what we call the bottom-up approach, which involves a lot of participatory action research methods, which is totally qualitative. And of course, we end up with a research design that is a mixed method. So we keep doing all the measurements and we keep doing all the anthropometrics, but we have to then go and do focus groups and interviews and get all this qualitative data that I was never done. And this is the first time I'm doing. And that's why I decided, or we decided, that we needed to, move and increase the team members. And for that, the first thing we've done was obviously, and I will tell you why I met this person who studies language, and we start having a Mayan translator with us in the field, okay? Because language is a barrier. It can be a resource, but we need to control this variable to understand health outcomes. Okay, so we need to start including language, especially when we have a mainstream language, which is the colonizing language, and then the indigenous language is something that people don't pay a lot of attention. And then we have to spread out the news about what we do. We have to go outside academia, and we have to start working, with NGOs. I mean, I work with museums and I work with schools, but we also have to start working with other organizations that are already there and start sharing resources. And that's where I am now. It is a new day for me because I'm really moving not away from the traditional ways of doing biological anthropology, but I'm including and involving people that usually we wouldn't, just because the areas are not so close together. So this is my team. And this photo was taken last year, not last year, in January of 2020, just before we were all locked down for COVID. So we didn't know about COVID. I mean, it was already talking here, but we were collecting data, doing research with the Maya, and we are actually involving the Maya families, mostly the mothers, in the research design of something that then we were supposed to be doing now, but of course we are not because of COVID. So this is me. This is Sabine Little from the University of Sheffield, and she is in the School of Education, and she studies bilingualism as a way of understanding ethnic identity. And she's totally a qualitative educational methods person. This is Maria Teresa Castillo Borget, short, we call her Tere, and she's in Mexico, and she's been working with us for a long time, and she's very good on all participatory action research methods. She has a great deal of work done with groups of women, activists, and she's invaluable on all of them are invaluable. And this is Hugo. He was my PhD student, and he's the one who did the 3-generation study, and he's now at Universidad Modelo. And this is Leah, who is the Mayan translator. She was a student of Tere, and she has a business with her mother, working with Maya bees, and so she has honey and candles, and she is very very active also in terms of rights of the indigenous people. So this is the group that we put together, and we started this new adventure of including qualitative and language and other variables that are a little bit further away from the traditional bioanthropology kind of variables. So in 2019, so a year ago, a colleague sent me an email saying, oh, there's these sandpits, and I'm not sure if in the United States you are aware of the concept of sandpit. Sandpit is the idea that you put together lots of people for a couple of days in a very nice closed environment. They feed you lots of good food. You don't know these people, but at the end of the time there, you end up with a proposal or with a paper or with whatever, okay? And there was this call by the Royal Academy of Engineering asking for people to apply to this sandpit, to this group. And I'm like, what am I going to do with the engineers? I don't even can put the IKEA together, you know, an IKEA chair together. Definitely, I don't have anything to do with engineers. But then I read the email a little bit better, and the email was the first 2,000 days of life, inclusivity and well-being in the first 2,000 days of life. And this would be in Cambridge from 10th to 13th of March, 2019. And the idea was, we're all going to go there, and this is all people from all around the world. People, you know, engineers, you know, people working in artificial intelligence, psychologists, people from education, people from the arts, medical doctors, you know, all of us anthropologists, and we were all get together. So we all went there, and there is really not a lot of structure because you start knowing people. And the idea was, this is the topic, inclusivity and well-being. We want to address the 2,000 days of life, first in terms of health and well-being. And by the time that we are done with it, we had formed the group, and they would give us, they would open a funding call just for the people who attended this group. So the chances of any of us at the end get funded were very high. And they would give us a pot of £20,000 to start a project that otherwise would never come together because you would not meet these people. And it sounded very appealing. So I applied, and I ended up being accepted. And then I met Sabine. On the second night, we were going on the bus, and I'm pretty bad on the, you know, on any bus because I get lots of motion sick. So I was just looking very, you know, I was very stressed and just talking to Sabine, looking at her on the corner of my eye. And I said, so what do you do? And she said, well, I study bilingual families. I want to see how these families navigate their languages. And then what's the impact of bilingualism on identity and well-being? And suddenly, in the middle of all my, you know, motion sickness kind of, you know, trauma, I was like, hold on, we have some research back when we did some research with the Maya kids in the States that gave us an indication that the kids in the US whose families continued to speak Spanish or Mayan at home, they tended to be less overweight and obese. So we said, okay, so do we have something here? And then suddenly it hit me that, well, there's this comment on the Lancet Global Health by David Floyd and Peter Roloff in 2018 about language and health. So we dug that out, and it's just a comment, and it's called Indigenous Language and Global Health. And these two colleagues made a comment saying that, and it's true that most of the times Indigenous languages are not discussed in global health terms. And they consider this a gap. And then they move on and say that they believe that Indigenous languages are relevant within the field of global health for reasons of autonomy, rights, ethics, the efficacy of the programs, and actually the revitalization of the languages itself. And Peter Roloff works in Guatemala with some of the Maya groups in the highlands. So this is the link for the commentary. And they end up concluding that global health workers and researchers must recognize the role of language when working with indigenous populations. the alternative approaches, which is to treat language or indigenous language as a barrier, or even worse, to avoid indigenous speaking populations altogether, is not acceptable. So Sabine and I start thinking, do we have a proposal here for this seed corn funding? What if we put together what she knows about language and bilingualism and what I know about human biology? We have already good research published in the global Lancet, Lancet Global Health, that serves the basis. So can we do something else? And actually we could. So if you remember, we went to that sandpit in March, and by the beginning of April, and this is the dates in European style, so this is 9 of March, not 4th of September, so 9 of March 9 of April. So a month later, we were awarded this funding from the Royal Academy of Engineers to study communities, language, identities, and belonging in participatory healthcare interventions. And basically what we suggested was, we're going to go to one of the rural Maya villages in Yucatan. And we went there from 18 to the 31st of January, 2020. And we will be doing participatory action research. We will be talking to parents. We will be talking to teachers, to the healthcare practitioners. We've interviewed the head teacher, and we're going to go and also interview a Maya traditional Maya healer. And so that's what we did. And basically the topics we wanted to know was, even before we started doing some research design to then ask for more money, let's really make sure we hear the voices of the people. So we wanted to know more about how do they use language and what language do they choose to talk at home, how language affects their access and their navigation to the healthcare systems, where, how, and in what circumstances and in what languages healthcare education for parents took place, if they had any. Then we also wanted to know the parents' perceptions of the traditional healers and the traditional medicines, which are prevalent. They are very, very, they're still very active in the area. And how do they connect those practices with westernized medicine? And then I wanted to really know what parents really felt about things that we call non-invasive or minimally invasive. Okay, because when we go and we measure kids, and there's a photo here of me measuring one of the mothers, and that's purely for presentation purposes. We are not collecting data on this mother. But we never ask the parents and the kids, is this okay to do? I mean, we assume that taking height and weight and skin folds is non-invasive. We go there with our aura of power of, Dr. Science knowing more than you do. And they say yes, and then the school say yes, and then they sign a paper, and we assume that it's all fine, but we never bother to ask them exactly if it is okay. So I wanted to change that, and I really wanted to talk to them and go measure by measure, wanting to know exactly what they feel about each of them. So we are still analyzing data. And as I said, qualitative analysis is something that it's totally new for me. So I'm really learning a lot and reading a lot, but relying a lot on Terry and Sabine to really, lead the group on that. And basically, in terms of the teams, we did a thematical analysis approach, and we've identified, so we knew that words and terms like language and family and health and identity and language barriers would be something that they would talk about. But now we are figuring out and analyzing the data into sub-teams because we understand that language is negotiated differently by the parents than it is by the children. And then the grandparents also have a different layer of interaction with languages. And the way they interact with languages show and gives them resources or determines to then go through the health centers and through the health system. And we are now understanding that in some way, in some situations, this concept of translanguaging, meaning that they speak in their families and they mix the languages. And actually that's a good thing. And they wish that teachers and healthcare providers could do a little bit more of translanguaging, because they think that would benefit the outcome. Okay, so in terms of the results so far, most parents are bilingual, and we are at a crucial point in time where the parents now, this current generation of parents, serve as the bridge between generations. So their own parents speak mostly Mayan, their own kids speak mostly Spanish. So they are the bridge between two generations. And we asked them about which languages they felt that it would be more important for the kids to know or to keep using. And we had some diversified answers. And mostly what the parents were very unanimous saying is that children should learn both languages and they should be fluent in both languages. And then there's a division in terms of in the way they use Spanish and in the way they use the Mayan. So Spanish was more closely linked to any future-oriented thinking, such as education and employment prospects. And Mayan was more connected with community and family. But they were very clear saying children should know and be fluent in both, because it will help them connect with the grandparents, but it also helps them connect with jobs. Okay. So the parents overwhelmingly agreed that access to bilingual Mayan, Spanish speaking healthcare would be their first choice. So we asked them, if you had 2 doors in the health center saying Spanish speaking doctor, Mayan speaking doctor, or another door saying this doctor speaks both languages, the parents all said we would go to the one who speaks both, because there are words in Spanish that we don't have in Mayan, and there are words in Mayan that we can translate in Spanish. So if they speak both, we can tell about our health problems in a much more, in a much better way. So everybody, even the parents who did not speak Mayan, also thought it was a good idea to have bilingual doctors in the health center. Okay. So regardless of their level of confidence in Spanish, in Mayan, having a bilingual doctor would be their first choice. So parents cited the needs of the community as a whole and saying that the community to flourish needs flexibility to be able to express themselves in both languages. Again, because some words don't translate. And we had that's still being analyzed, but we had some questions about when you want to express emotions, what language do you choose? When you're hungry, what language do you choose? So they're still being analyzed. And then something that was really interesting to see is that the teachers that we interviewed, they do not speak Mayan. When we interviewed the nurses and the doctor at the healthcare, all of them said, oh, the teachers can teach the kids to speak Mayan because all the teachers speak Mayan. And this is in a village that there's about 100 meters distance between the school and the health center, and they all know each other. But the misperception between what the teachers can do and what they can, and what the healthcare think that the teachers do is absolutely worlds apart. Then we asked the mothers and fathers, because we were able to get fathers to attend focus groups. We have a very clear preference by gender. So women, the mothers prefer female doctors, the fathers prefer male doctors. But when it comes to treating their children, they don't care as long as the doctor is good, and only competence matters. And we didn't know about this, so I think it's a good thing that we asked. And then I got a list of all, with photos of all the anthropometric stuff that we do for ages and ages. And we basically just say, oh, it doesn't hurt, or it's just a pinch on your arm, but we really wanted to ask, is this okay for us to do this to your kids? So we asked to all the parents, can we take the height? And we showed. So this table summarizes what the parents think. Height and weight, no problem at all. Circumference is no problem at all. Skin folds, however, no problem, but the mothers want to be with the children because they say otherwise the kids may get scared. Bioelectric impedance, the same. No problem if the mothers are with the children, otherwise the children may get scared. Finger pricks for blood analysis. We've never done that because when I came for the first time to the Yucatan, I was told nobody takes blood from the Maya. And I said, fine, nobody will take blood from them. So we don't have any biomarkers at all, ever. But we asked them, would you be okay, or what's your opinion about us doing a finger prick to test for, markers of, to see how your health is? And they said, no problem. If the mothers are with children, otherwise they may get scared, obviously. And then the mothers were like, wow, why did they stop doing the anemia tests at the health center? So we didn't know, but we realized that the health center was doing anemia tests through finger pricks until maybe 4 years ago, and then they stopped because of funding. And the mothers who were there, not a single one went to the health center and asked, because they don't think they have the power to go to the doctors or the nurses and ask, why did you stop anemia tests? But they say, no, can you do them? Because if you can do that, that would be great for us. And we want to know how the anemia are, because then we can make decisions about the foods that we eat or the things that we can buy. So it was a big finding to realize that we actually can do finger pricks as long as the mothers are with the children. And it's something that they really welcome, not just because it's for research purpose, because it's for their own benefit. Taking blood from the vein, absolutely not, in any circumstance, not even think about it. Saliva samples, yes, I didn't have space on this table, but for saliva, either the swabs or the spitting on the tube is perfectly fine. And then the blood pressure, we actually didn't ask, but the parents asked for themselves. And they said, can you do blood pressure for us? Because again, we don't have time to go to the health center, and sometimes we go when the nurse is not there. If we could get our blood pressure checked here at the school when we come and bring the kids in the morning, that would be so helpful. And we said, yes, we can do that. We will put that on the research design, but rest assured that you don't have to be part of the research to have your blood pressure measured. You can come at any time and we will do that for you. And that gave me a sense of that I was actually listening to the people, and it made me feel better. So that was it. And now in terms of what we do now, so this is the bottom-up approach, is to get the people together and really make the research design taking into account what they say. But then once we have the results, it's not good enough to just publish the papers and write another grant. Definitely, we have to go back to the community and report. And for some reason, this is in a wrong order. So we are working now in the reports to send back to the communities and to the Secretary of Health, both in Spanish and in Mayan, because we are now translating everything. We are starting, and Katie said that I'm the director of the Maya project, which I am, but I don't give the website now because it's getting a full revamp, and when it's ready, then I'll share with you, because I'll be starting new web-based educational activities. Dissemination, one of the readings I gave was something that I was asked to do for the Virtual Museum of Human Ecology in Spain, and that comes from the Universidad Autónoma of Madrid. And basically they asked me to put together a group, some research photos that would put together the problems of malnutrition under and over in the context of the Sustainable Development Goals. And that's what you have in the link that I sent. So I hope you enjoyed it. I had, lots of fun doing it. And the next thing I'm doing now is community engagement working with what we call here a charity, which in the United States you would call an NGO. And I got a little bit of enterprise money, which enterprise is, you don't call it enterprise in the States, you call it something else, like the outreach. And I got a little bit of money to do this thing that is called Cards for Health. Okay, oh, so this is the virtual exhibition. So that's what I've done. And the Cards for Health now, I partner all the people that you've seen here, plus Samantha, who is a nutritionist, and she is Maya as well. This is Claire, who is the director and CEO of Children for Health, which is a charity that is dedicated to the promotion of health education in developing countries, focusing on developing children as agents of change and communicators of essential health messages. So basically what Claire does, she trains the kids in a health outcome or an activity that will promote change in behaviors and will promote better behaviors. And the children will be empowered to then be the agents of change among their families and among their communities. And what we are doing now is what we call the Cards for Health. Kids in Yucatan, they love to play cards. So what we are doing is cards for nutrition, cards for basic hygiene, cards for physical activity. And we are actually hiring Marcelo and Deira, who are Mayan activists and artists, for them to do the drawings of the cards that then we will train the kids, and the kids will get the cards and they will be empowered with knowledge to go and explain why other people should change their behaviors for better. So this is the drafts of the cards based on the messages. So this is to wash your hands. This is to check for basic health outcomes based on measurements, so to take it to the health center. And this is to promote healthy eating. And we really want to make sure that we give the ownership of this artwork to the community and to the Mayan artists. So that is very much in the beginning. These are just, as I said, the first drafts of the drawings, and we are now in the process of giving feedback. And then we'll be piloting these cards, and we will be giving then these cards for the communities, for the kids to just go and take over. So that's the last adventure on all of these. So I think I reached the time of, to say thank you. And that's my email address. Being Portuguese, I have 5 names, which will reflect in all of these initials here and my hyphenated name. But by all means, get in touch. And thanks so much for listening. And my apologies that my computer crashed in the middle. Let me see if I can get out of here. I can. Shall I stop sharing?
Yeah, then we can see, we let people decide if they want to be on camera or not when we come out for a Q&A. So thank you so much for that wonderful presentation. I will suppress my many questions and open until a little bit later, and open the floor to welcome anybody that would like to ask questions about the presentation. Please, now you can ask them directly by turning on your audio, or you can submit them through the chat and I will amplify them for you.
Thank you very much. This was lots of fun.
This was wonderful. I love that you're returning to first principles and are and reassessing how people feel about the different kinds of measures that human biologists are doing, and the mixed methods.
That's a bit of a discussion that we should have about those methods that are so ingrained that people don't even question them anymore.
Yeah, and I mean, I wrote down several people.
Okay,
lots of good talk messages through the chat. I loved the point you made about how we go there with our aura of power. Yes. And I mean, I think when we put this in a historical context, when a lot of human biologists began working with subsistence populations decades ago, I surmise that that aura of power was even greater. And so these practices got established when the power differentials were even more extreme. And so I think the highlighting that we need to return to these things and interrogate these practices with positionality in mind is such an essential perspective. So thank you so much for showcasing
the
best practices about doing that.
No, the first time I went there and I went on the field. So there's a very good colleague of mine, Federico Dickinson, who is also my co-author and has been since the beginning the main point of contact and the main co-author of myself in all projects except this one. And not because of any reason, because he was doing something else and he's about to retire. And we needed Terry as the more qualitative person. But one of the first thing that Federico told us when we arrived there was, when we go to the field, nobody wears anything that remotely resembles any military gear or any white coat that resembles any medical profession, because that will provide you with power that you don't want to have. That will provide you with an aura of authoritarianism that will press people to abide by what you want to do against their own wills. And obviously what he always put, and that's really great, I learned a lot, doing field work from him, is that the people who don't look Maya are the ones who are going to stay on the background, because we have lots of people here who are Mayan. They are the ones who take the charge. They are the ones who talk. And I think it's the right thing to do. It's to empower colleagues who have much more right to be there and much more legitimacy than us trying to make a point about something that is ego related and not, research related the way I like to conduct research. So absolutely.